Welcome back to Mic'd Up with Chiro Up. You've got Tim and Brandon for this podcast. I'm going to cover the first half of it. Tim's going to cover the last half of it. You kind of already know the drill if you've listened to past podcasts. This is going to be designed to sharpen your clinical skills. We try to do it in 30 minutes or less with practical evidence-based insights for chiropractors. Now, the 30-minute number really comes if I'm doing the podcast. If Dr. Bertelsman is on the podcast, it may take a touch longer. Luckily for you, when I recorded this first part of the podcast, it was during his afternoon nap. However, I did wake him up for the last section, and I do have to admit he gave us a couple clinical pearls and some pretty informative and exciting stuff on the EHR. So that's going to be at the end of this podcast for those of you who are not in the middle of your afternoon nap. As always, before we dive into the episode, if you like this episode or past episodes, please show us a little bit of love by hitting that like button. Most importantly, share this with people that need to hear this message. Those providers, those chiropractors looking to put the patient first and clinical results above everything else. I do appreciate everyone for their feedback and the audience that has continued to grow over the years. And really, this podcast here, just like every other one, was developed in response to the feedback that we're getting from people like yourself. So today's episode, what are you getting into? What am I getting into? It really goes through the pieces of carpal tunnel syndrome diagnosis. Not so much focused on that specific diagnosis, but we will get into that. I think it's more upon getting the right diagnosis first. So if you're looking for a pure carpal tunnel syndrome rundown, I'll get into how to find those things. However, today we're going to cover three essential sections. The first two are going to be over how to diagnose carpal tunnel syndrome. I'm going to give you the best orthopedic tests. I'm going to give you which ones are backed by solid evidence and which ones are, I don't want to say wasting your time, but maybe not getting the most information out of as far as specificity and sensitivity. Then I'm going to tackle something most clinicians might overlook, which are negative orthopedic tests. Why? Because what a test doesn't tell you is sometimes just as important as what it does. So how can we rule out conditions instead of just ruling in conditions? Don't worry, I'm going to keep it short, practical. I'm going to throw in some real world scenarios, and I'm also going to give you some ideas on how to document that in your notes without writing a novel. And then finally, I'm going to go through those of you in the trenches of practice management, those of you who are working on getting your practice and scaling your practice. I'm going to go through an update on what we've learned from the first 50. Essentially the first 50 clinics using the EHR, all of these beta clinics. I mean, these clinics are, people who are giving us consistent feedback. We're turning their dreams, their functionality, their needs into their own EHR. The most surprising things that we've learned, and we're going to cover, Tim and I, and there's a lot, and not necessarily a bad thing, but everybody practices a little bit different. So we'll go through a couple of those things to round out this podcast. All right, so to jump into the clinical side of things, going into the diagnosis of carpal tunnel syndrome, I do want to point out that if you're looking for treatment strategies concerning CTS, there's a lot of different things you can do as far as the management, the rehab, the treatment. You can look at our podcast. You can look at our blogs. The last podcast in July 2023, I did cover the entire evaluation and management of CTS. And of course, you can go back into Chiro Up and look at those things. Everything in that podcast, everything in Chiro Up is 100% evidence-based. Keep in mind, in the podcast, I do reserve the right, and Tim reserves the right to throw in maybe 10% of opinion. We like to have a little more conversation, so keep that in mind, that I'm going to give you some real-world advice. I think that's important to not just be 100% evidence-based, but also have some experience rolled into that. After getting a flood of questions after that diagnosis podcast, I knew I wanted to give a refresher, because the number one question that I heard was, how do I know if I have carpal tunnel syndrome? So those podcasts and a lot of our blogs are based on having the diagnosis CTS and then what are the clinical best practices. And I don't know if anyone's had this. Let's be real. None of us, for ourselves or for our patients, want to jump straight into nerve conduction velocities studies. If we don't have to, let's not do that for us or our patients. They're expensive, they're super uncomfortable, and not always necessary. So when a patient walks in And sometimes they're convinced they have carpal tunnel syndrome. Really, as a provider, I'm looking for what orthopedic tests, what symptoms, what signs am I looking for that to confirm CTS, or, sometimes, just as important, refute that diagnosis. So just to, set the stage for this demographic, those patients with carpal tunnel syndrome, these are the people with that paresthesia, dysesthesia going into the hand. Usually they're getting that numbness and tingling in that first 3, maybe 3.5 fingers. Everybody's wired a little bit different, so not everybody falls into a chapter in a book. However, what we'll see with a lot of these patients that have had it for a while, they will get that hand falling asleep, but usually after a postural adjustment, after changing positions, it'll go away quickly. So that's the patient, waking up, their hand's numb, but they shake it, and within seconds, it's coming back. Now, if that turns into a long-term scenario where they're not getting treatment, it can result in thenar muscle weakness and atrophy. This would be an opinion piece of this podcast. I've never seen that come back. Once we start to get weakness in muscles, can we build strength? Maybe, but are you going to get it back? Probably not. And then finally, to confirm these, the traditional test, a positive phalanx test, which I am going to comment on. I learned something new in the last month, and I want to relay that to you and give you the evidence behind it. However, a positive phalanx test with a Durkin's test, essentially squeezing the carpal tunnel, can help get to that diagnosis of carpal tunnel syndrome. So I really want to dive into, a patient comes in with those things. How can we make sure this is the diagnosis and not something else? And to do that, we need something called negative tests. And we think of a negative test, and the patient thinks of a negative test as a fail, meaning the doctor did something to me and it did not reproduce my symptoms. However, what I'm going to hopefully convey today is that those negative tests are just as important as the positive test, not only in your evaluation, however, also when you're taking your note. It's important for you and any kind of insurance reviewer or any kind of person who's looking at and auditing your notes to make sure that this was the only diagnosis that was realistic at the time. So, orthopedic tests play a crucial role in diagnosing musculoskeletal conditions. However, we can't just focus on those positive tests. These negative tests will provide valuable information, and kind of here's why. So I want to go through a couple of things. I've got, I think, 5 things that I want to cover. And one is ruling out competing diagnosis, because a negative result, like in this case, a negative phalanx test, it doesn't mean they don't have carpal tunnel syndrome. It just means that, carpal tunnel syndrome is very, very unlikely to be causing this symptom. So immediately, if I have a negative phalanx test, but I have numbness and tingling in the first 3.5 fingers, that's okay. That just tells me that compression, that hand numbness and tingling is probably coming from something else. Maybe I need to look at more of a cervical radiculopathy or a thoracic outlet syndrome. And we can use tests, in that case, phalanx tests, but if you look at the knee, if I have a negative anterior drawer test, could they have an ACL tear? Maybe, possibly, but very, very unlikely. So, if I do one quick anterior drawer test and everything looks solid, I'm going to be guiding my attention towards what else be causing that anterior knee symptoms, like a meniscus tear or maybe an MCL sprain. So we can think of a negative test not as, it's not that. However, this is just ruling out one possible cause of that symptom set. Now, another thing that a negative test can do is increase diagnostic accuracy. So we're going to reduce these false positives. So some orthopedic tests lack specificity, meaning they might produce false positives. So in a patient without a condition, we really need to consider these negative results so we can avoid misdiagnosing or any kind of over-treating. So, if I have, let's say in the shoulder, a Hawkins-Kennedy test for shoulder impingement, it's positive for a lot of things. It's commonly positive even in an asymptomatic population. In fact, go up to anyone who does not have shoulder pain at all and do Hawkins-Kennedy, and often you're going to find, that actually does hurt. So a negative test strengthens the argument against something else. So I think that's something else important to identify. It can also identify alternate causes of symptoms. So if all tests versus suspected condition come back negative, that's a problem. Meaning if I go through my entire orthopedic examination and nothing reproduces their problem, what should we be thinking? Well, in my mind, we should be thinking about non-musculoskeletal conditions. So if I go through all my orthopedic tests, for a lumbar spine disc herniation, they have constant burning, searing, pain, discomfort. Well, yeah, I could say that's probably not a lumbar spine problem. Maybe it could be a hip problem, but really, we should really be kind of looking at more of a visceral problem or an infection problem or something that is not musculoskeletal related. So that's something that I really think has I thought about when I was developing a talk that I have to do in the next couple of months, is that the great mimickers, the things that, we're confident it's a back problem. You do all the tests and they're all negative. We could scratch your head and say, oh, maybe we need some imaging or something, or I need to send you to someone else. However, that's a sign that maybe that problem, while it's creating symptoms in that region, is not actually caused by an orthopedic diagnosis in that region. We see that as a common thing when it comes to hip and back problems. If you do a negative Faber test, they probably, if you have a negative Faber test, it's probably not a hip problem. It could be something that's coming from the back. It could be something like a hernia or pubic symphysis dysfunction, something like that. I also think negative tests, as far as number 4, avoid unnecessary treatment or intervention, because whenever we have like a false positive, that can really lead to unnecessary treatments, surgeries, injections, prolonged therapy. They can really prevent mismanagement. If I had that same patient that has, numbness and tingling the first 3.5 fingers, and as a chiro, they have some neck symptoms also, and I get just focused, laser focused on cervical radiculopathy, but I never go through and I test other things to rule out it's not pronator tear syndrome, it's not carpal tunnel syndrome. I could be spending all my time and energy at treating the neck when maybe the neck was associated with it, like a double crush injury, but maybe it's something down the chain. So using negative tests to make sure that we have the right diagnosis. Also, I think the last piece of negative tests, it really strengthens our use of clinical prediction models. That in evidence-based medicine, our diagnostic decisions rely on I want to say a balance of positive and negative findings, because we need to know the most sensitive and specific test on what a condition is, but we also need to know, when we can rule things out by using negative tests to refine those probability scores, so we can choose the next clinical prediction rule. So, at the end of negative tests, really positive tests suggest what a condition might be. Negative tests clarify what the condition is not, and then together it helps us define what a differential diagnosis is. And to do this, when we can do this, it creates confidence in us, it creates confidence from the patient, so we can have an accurate and really effective treatment plan. So next time, instead of thinking about what's positive, or really ask yourself what else is negative. So, keeping that in mind, keeping in mind with carpal tunnel syndrome, what else could be causing symptoms like carpal tunnel syndrome? Could it be tendinitis? Could it be osteoarthritis of the hand? Could it be cervical radiculopathy? Could it be nerve compressive disorder other than carpal tunnel syndrome? Those are the things that you have to rule out. Interestingly enough, one of the main components of numbness and tingling stinging of the hand can be osteoarthritis of the hand, which is, kind of interesting that just more of a space occupying lesion. I think the base of the thumb, the carpal metacarpal joint, the CMC joint essentially, I think it's number 2 or number 3 of the most common location of osteoarthritis within the body. So something else just to kind of think about when it comes to this diagnosis. Now, let's go into carpal tunnel syndrome. Let's go into this specific diagnosis, and I'm going to cover for you the most common tests that are used. And then I'm going to give you I don't want to say a new test, but I'm going to give you another interesting test, which actually increases your diagnostic probability of having carpal tunnel syndrome. It's really just a spin of an old test. So first, Tunnel sign. This is the classic tap test. You tap over the carpal tunnel, or really any area where you can expose the nerve, and then do they feel tingling in their fingers? The sensitivity is like 38%. Specificity is right around the same number. Translation, it's literally hit or miss, pun intended. It's just going to fail to pick up many cases. It often misidentifies people who don't actually have carpal tunnel syndrome. If you have irritation of a nerve anywhere along the chain, you could actually have a positive Tunnel sign. So if you're using that, maybe. However, there are better tests. Now, Phelan's test, which I've actually already talked about a little bit, this is the one where you're going to hold the wrist in full flexion. And really, essentially compressing the carpal tunnel by putting the back of your hand together. This is going to be interesting because the sensitivity is really low, around 50 to 60% from my recollection. I'd have to go back and look in Chiro Up. But this is barely better than a coin flip when it comes to accuracy. So it's one of those things that it's a good screening test, maybe. However, if you're just doing Phelan's test for a couple seconds, not a great one. Reverse Phelan's, it's the same concept, but this time you just have your extended hands. Now you're actually stretching the carpal tunnel instead of compressing it, creating some traction ischemia to the nerve. It makes sense in theory, but reliably, it's just not that great. It's about the same as Phelan's test, so still questionable. Durkin's test is a little better. And I've always called it just compression test of the wrist because I'm a little more informal, but Durkin put his name on it. He was a little ahead of me. This is when you're going to put direct pressure over the carpal tunnel for about 30 seconds. And guess what? When you create sustained compression over a nerve, it's going to reproduce symptoms, sensitivity in the 90s, specificity 96, negative predictive value up at 94. This is more like it. Durkin's test consistently outperforms the others, making it best of the traditional bunch. But here's the thing. Even the best tests aren't perfect, so we have to use a combination of tests to become more reliable. So I think that's kind of the at-home message across all areas of the body. We always have clinical prediction rules to make sure we have the right diagnosis. Now, here's my issue, is that I really like those tests. I've got no problems with those tests at all. However, there is some new research that I'd like to bring to everyone's attention called the timed Phelan's test, the TPT. I don't know if that's actually the acronym, but that's what I'm going to use because it truly is the acronym. Phelan's test has traditionally been used to diagnose carpal tunnel syndrome. Its accuracy does vary widely, and I think mostly because not necessarily the movement, it's more for how long they hold the movement. So the timed Phelan's test is going to apply sustained wrist flexion, and the sustained wrist flexion is about a minute. Now, a minute is valuable. You, like I, trade time for money. So spending a minute doing a test is an expensive endeavor for you. However, when someone really has that idea they have carpal tunnel syndrome, you and I and the patient need to make sure we have the right diagnosis. Our positive predictive value with the TPT is at 96.6, specificity at 96.8. This is a pretty practical and cost-effective minute. I think this is something, I only found one study on this, so it's probably going to require more studying. However, I do think the TPT, essentially spending an extra minute, is superior to the traditional Phelan's test, or something that we should all think about doing. Now, so that's a little bit different of a test. I want to cover that, and I'm going to cover one more. Before I dive into that, I think that it's at least worth saying that there are some things the patient can do. One, ultrasound. Very, very good. It's probably the most effective non-invasive method to diagnose CTS. So there's that. Obviously, most of us don't do that in our office, but huge sensitivity, specificity, positive predictive values above 95%. And then you can do something called diffusion tensor imaging. That's an MRI essentially for CTS. Also similar numbers. So ultrasound and MRI can, of course, be used to make this diagnosis. However, I said that I was going to give you things you can do in your office as a chiropractor. And one of the things that I found was another study on a new test, or at least a new test for me, I guess, is called the pronation compensation sign. And I'm going to explain it, and then I'm also going to have us do it. It has a very high sensitivity. And what this is a new way to detect carpal tunnel syndrome. And it's actually kind of a functional test. It's kind of like doing, like a single leg squat, or, testing for scapular dyskinesis. And what it does is it's looking for compensation. So normally the abductor pollicis brevis, it's the muscle of the thumb, is controlled by the median nerve. So it's going to help bring that thumb into palmar abduction, and it's going to bring it forward or anteriorly, and it's going to bring it closer to your pinky finger. So we can use it for that. We can also use it for thumb opposition and extension. When the median nerve is compressed, especially when it's been compressed for a long period of time, this muscle is going to weaken. It's going to make it harder for you essentially to lift up your thumb. So your body, like every other part of your body, is going to compensate. So it's going to unconsciously, well, I shouldn't say that. The brain is going to consciously make this compensation. You unconsciously make this compensation. You don't even know you do it. It's kind of like when someone picks up their arm with a rotator cuff problem, they start to shrug their shoulder. That's a compensation for a weakness. So what your body's going to do is to unconsciously pronate their wrist. And this is going to be kind of cool. So wherever you're sitting, unless you're driving, don't do this. However, if you're sitting in front of the computer or wherever you are right now, put your hands down on a table. So have your arms at your side, elbows at 90 degrees with your palms up towards the ceiling. And then what I want you to do is I want you to slowly bring just your thumb. Don't move any other fingers. Just try to move your thumb up towards the ceiling. So it's essentially pointing up 90 degrees towards the ceiling. Now observe your second metacarpal phalangeal joint. So observe your pointer finger. Does it go along for the ride? The people that have weakness in that thumb or weakness in thumb opposition, they can't do it. That muscle's not strong enough. It's not coordinated enough. The median nerve has been compressed. So instead, their body has figured it out, and now the entire wrist is starting to pronate along with that movement. A positive test is when you see not only is the thumb going up, but that second metacarpal joint is also rotating up towards the ceiling in more of a pronated position. So the pronator teres is essentially helping that process go along. So in conclusion, looking at all those things, the most sensitive test that you can do in your office for the vast majority of us is that timed valence test. The sensitivity is near 100%. An emerging test that we learned about was a pronator compensation sign. We don't have that in chiro yet. I'm sure I'll get that in a video format pretty soon. The best overall test, which most of us probably can't do because we don't have an MRI, is an MRI. And then the most specific test would be actually an ultrasound-based diagnosis. However, once again, not many of us do that. If you want any other additional tests, make sure to dive into chiro and to look at that. And don't just look at the carpal tunnel syndrome diagnoses. Also look at other ancillary diagnoses like cervical radiculopathy, like pronator teres syndrome. And then also, even though they are different fingers, the condition reference for thoracic outlet syndrome, 90% of thoracic outlet syndrome, they show symptoms in the fourth and fifth finger. Something to think about with your next patient. So for the finale of this podcast, I'm going to turn things over to a Q&A session with Tim and I. I asked him a couple questions about the release in the EMR, and I was actually really excited to hear his responses. So for those of you who don't know, Tim and I work together in our clinic on the chiropractic side, and then we also work together on the chiro side. And it's interesting because we work together in both businesses, but we don't often get a chance to just chit chat. So I'm interested to hear his response. I've got 5 questions that I'm going to pose to him. And now keep in mind, all these questions and answers are from February of 2025. If you're listening from the future, hello. I understand that some people go back in time with podcasts, but without further ado, here's my interview with Tim on understanding what we are doing with the EHR and how we're formulating what comes next, because that's probably the most intriguing part of what we do as a company. ChiroUp wasn't just designed and then we created it and then it's there for 10 years. It continually evolves based on subscriber feedback. So how are we taking that same mantra and turning that into an EHR? He's going to shed some light on that and how we're turning it into not just for our beta group of 50, but how in the next year we're going to be scaling that company to make sure we can service more providers that want to practice like you and I.
Can't get enough of the information you hear on our podcast? You will absolutely love our platform. ChiroUp helps thousands of chiropractors across the globe simplify the way they practice using our online evidence-based software. It's your one-stop shop for powerful clinical research, simplified patient education, and smart practice resources. Visit chiroup.com, try it out for free. And if you'd like to subscribe, use referral code podcast15 for 15% off 12 monthly billing cycles. No contract required. Offer valid on new subscriptions only.
All right, I'm just sitting down with Dr. Bertelsman, and I've got the 5 questions ready for him. He has not seen these questions, which makes it really exciting for me. Normally, when Dr. B walks into a room, he has a legal pad, and on his legal pad, he has every task list, every question that everybody's already asked. He has his entire day scripted, his entire week scripted. He knows exactly what's about to happen, and this is going to be fun because he has no idea what 5 questions I'm going to ask. Are you ready?
I think I have to go to the bathroom.
I feel like it's a game show. In fact, I went to a game show. Have you been there? The game show? It's called The Game Show.
No.
It's a place where you can play like Family Feud, Wheel of Fortune, The Price is Right, and Plinko all in an hour. Super exciting. That is an unsolicited plug for that. It was actually really fun. We dressed up in like 70s attire and went down there and had a ball.
So you just went straight out of the office.
Exactly. All right. So EHR-wise, this is the thing that I keep on getting all the emails about. So I want to plug a little bit of EHR stuff. I know people are excited. Keep in mind, this is February 2025 is what that's where I'm coming from right now. So things have probably changed by the time you've listened to this. However, Tim, what has been your biggest surprise in our first 50, the first 50 that have gone live?
Other than it works, that's a good thing. We've been using it in our clinic a while. My surprise with what I think is that the kiosk adoption, that's the one big thing that's really different. There are a number of things that are different about our system, but one is that patients check in with a kiosk. They can either do it on their phone before they come in or they can do it at the front desk. And I know that when we implemented this, I had a little bit of tension thinking about, what's going to happen to Gertrude? What's she going to do? And yes, there are the Gertrudes of the world who do have a little challenge when they sign in and they struggle with it. But I think the biggest surprise is how many patients just adapt to it. And that's true of our subscribers as well, that we don't really get any squawk from patients at this point. I probably have 6 patients who just can't use it. So I just take their subject of component manually or do it online in my office. But the other 99% of patients, they've adapted very well. And I think one of the things that's helped, and one of the tools that we're using with those subscribers as well, is setting expectations that really, if you know what's coming, things get a lot easier. So letting patients know that, hey, we're one of the early adopter offices of this pioneering software that's out to help improve healthcare, to provide better outcomes, to provide higher patient satisfaction. And in order to do that, we need your help. If you'll fill out this survey, putting signs up, explaining to patients, letting them know they're part of something special, that this isn't just extra paperwork. It's actually going to be less paperwork for everybody.
Yeah, I've had the same. I was very nervous, especially with that demographic, the older demographic that you're becoming accustomed to. But this is a demographic that doesn't like change, so I was a little bit nervous. However, I would say the same thing. Also, we made some adaptations to the survey system that those people using our Essentials product, don't quite see. So it's very simple. The average person for a new patient, it's right around 3 minutes, maybe 4 minutes, because it does include that functional disability indice. But that follow visit, it's 30 seconds, and now my subjective is done. So I like that answer. I would say that probably was my biggest surprise at the beginning. Now,
one that you're kind of scared about initially.
Well,
and
every change.
See that it's okay.
This is the question that I am very curious on your answer, because this is one that continually gets me. What common requests are we getting that you didn't see coming? So what are those things that those beta clinics are saying, hey, you need to create this that we just didn't even see coming? And keep in mind, we had a beta group, we had a focus group for, 18 months. We were constantly scouring those 20 clinics. What is the request that you just didn't see coming that people need?
That I think just the overall surprise of the number of things that people do differently, that we had the 20 clinics, we had single doctor offices, we had multi-practice offices, multidisciplinary offices. And so we tried to really think about all of those things. And I think just a lot of the one-off, if there would be one that wouldn't be the one-off, it would be online scheduling. That online scheduling has really become a prominent feature of a lot of clinics. I think some of the more progressive clinics, and we were not one of those, that we had online scheduling, but it wasn't our predominant method. There are some clinics that are almost exclusively online scheduling. So I think that would probably be the common request that some of those clinics have migrated to, that I didn't see that coming.
Yeah, I would have said the same thing. So I actually put a note underneath there because we had 2 clinics that wanted to collect a credit card before seeing the patient. I would have never thought of that. And I love that idea because if they don't show, you're charging that no-show fee without the patient coming. So those are things that when we get that, now we need to talk to the payment processor. We need to figure out how to do this. And so that was one that I didn't see coming, but also I think that now that in our clinic, we're benefiting from it. So it's nice to hear what's working for other clinics and for everyone to benefit from that functionality. Next, what changes have we made? So what changes has ChiroUp made to accommodate these needs?
Well, I would just steal your last answer that when the subscriber called in and said, hey, I really need to collect that credit card because I want to make sure that if they miss their appointment that I'm able to bill that missed appointment. So that was something that we did. And I think that our underlying philosophy, things that we talk about, and you know this, sitting at the coding and functionality meetings on a regular basis, we continually talk about we're here to serve the people that we're currently serving, that we're not necessarily looking for what kind of magical things we can do to bring in a bunch more people. How can we better serve those people that we're serving? And when we have a product that we know that 50 and then 100 and 150 people, it's going to catch fire on its own. So prioritizing those needs before new features, we have this huge, huge board of features, of cool stuff that we've thought up that we want to implement. But the past few months have really been spent on those needs that patients and the providers for those patients have. I think the biggest one would be super appointments. So this is releasing probably about the same day this podcast does, a week from today. And super appointments is more like cascading appointments, meaning that if you have a multi-provider, multi-service clinic where you have a massage therapist and a DC and an MD and a PT and a who knows what, and you have special rooms and special treatments, you're able to schedule all of that at once. So when the patient comes in, they schedule one appointment at 10 o'clock for the chiropractor, and then at 10:15 they're seeing the massage therapist, and at 11:15 they're seeing the PT. And we know what rooms that's going in. So all of that coordinating, which was really a massive overhaul of the system to be able to do that.
Yeah, that is a really big one. I mean, that change right there to meet the needs of our current subscribers with super appointments was a big lift. Another big lift that I saw was the billing improvements. And everything is, we've been using that Premier Rehab for 18 months now. Everything works perfect for us. And it worked perfect for the first 8 to 10. And then you start to get more clinics and they want different workflows. They want insurance verification. They want things to be automated based on the patient type or appointment type. And so that's the next question I want to ask you. What's the most encouraging news about integrated billing? And the reason I want to ask that one is because that is probably, from what we heard at the beginning, the hardest thing to do is that some EHRs have great scheduling, some have great notes, some have great billing, but nobody's been able to piece all these things together. So what are you excited about with the integrated billing service that we do have?
I'm going to repeat that earlier answer. It works. That, there's always a lot of nervousness when you switch from one system. We switched 5 different EHRs throughout our practice career. And sometimes that would mean a pretty significant lag in income for a period of time. So the biggest surprise is we didn't have a massive lag in income. That was good. I think one of our subscribers said it best, is that they're most excited that they said something like their story that they tell in their notes now matches the story that they tell on their claim form. And a lot of the EHRs that are out there were built either as a note system first, some of them, and then added billing later, and others were added as a billing system first, as practice management, which was what everything was 20 years ago. And then Obamacare said, hey, we need to have some notes in there too, so they added notes as an afterthought. None of our components were added, significant components were added as an afterthought. They were added as an integrated system, so that when I say a patient comes in and I select 3 areas of their spine that have joint dysfunction, my plan now says you probably should bill for 3 areas, and my bill says that there are 3 areas, and everything matches, so it tells the same story. I think that's the part that I'm most excited about.
Yeah, I can't really add anything to that. I mean, the exact same thing is that I want to tell the insurance a story that I have documentation of. And now, and I just got done with my notes. I saw my morning patients, and I walked in this room, and it's ready to go. So it's done. My notes are done. They're billed out for. It's just one of those things that just works seamlessly. That does bring my last question, is the future. So looking at what is present, what is working, everything's going great. However, what are you excited about? Because you said we are working on those things that subscribers want. What does Tim want? What do you want in this EHR that you're excited about that's going to be rolled out in 2025?
I mean, we have that huge list of things that we want, the cool stuff.
But if you had to be selfish.
If I had to be selfish, it's easy. It's what I'm practicing with now, and you're practicing with now. That we're using a test modal of a system that basically listens to the visit and then enhances our subjective component of the note. So all of those things that the patient tells you in the note that are unique, that really can't be collected by a kiosk, at least not of one of a realistic length, are now collected automatically. So what I'm excited about is I walk in and I hit a button, and at the end of that visit I hit another button and says, you want to add this paragraph of stuff the patient told you to it. That's what I'm absolutely most excited about. I was super excited when SOAP came out. I was super excited, that same feeling that we've talked about probably most every day that we see each other at the end of the day of, yep, all my notes are done. That's never happened. It was always recorders in the car on the way home and that nonsense. And now they're just done 100% of the time. I was excited about that. I think I'm even more excited about that additional paragraph that we're adding in, and that's just the start, which makes it even more bright for the future.
Yeah, I'm excited. One of the things that I've heard from people is, how are we going to incorporate AI and machine learning, and how is it going to do my note for me? And I think what, at least, and this is my point of view, I'm not saying it's right, is that I think that chiropractors are unique. And there are a lot of things that AI is going to be able to do for us. And we're going to be able to use automations in the background within this program and a lot of other things in your life. But we're going to be doing that, and we already are. But the trick of AI is going to be doing it without the need to actually do it. It's just in the background, like our billing rules. It adds modifiers. It adds the things based on the patient, the insurance company that you just need to have. And it needs to recognize the patient, recognize the insurance company, recognize the service, and then apply the modifier. So there's a lot of things we've already incorporated, but that is by far the number one. What I'd like to hear from you, the listener, is your biggest issue. And don't respond back with, doing my notes. Don't respond back with scheduling. What is that one specific granular thing that you would like fixed in your practice? What's that one thing? Is it how do I bill a certain insurance company and get reimbursed more? How do I take my subjective notes faster? How do I include more detail in my notes and be able to justify a certain code? Think about that one thing that takes the most time out of your day, and I want you to email me, brandon@chiroup.com, and that is going to be the next podcast. So I want to hear your biggest gripe, your biggest time suck throughout the day, and then we're going to turn around and turn that into a conversation. So that's my ask of you. Never end an ask with another ask, but I'm going to do that. And it's really just to make this podcast more known. I mean, if you enjoyed this kind of episode, please share with a friend or a colleague. We really want to get this information out here, both the clinical and the business stuff. This podcast is all about pushing our profession forward. And if you can spread that message, there's one way to do it. It's an easy way to do it. Hit the follow button. I'd appreciate, Tim would appreciate it. And I think that many more of you are going to be able to see the EHR service that we have out there in the months to come. Thanks for listening.
Hey, thanks for listening. To access more information, visit chiroup.com. You can sign up for a 14-day trial. Use referral code podcast15 for a special discount after your trial. Offer valid on new subscriptions only.